Welcome to the first student-led journal club case study. Today, I have the pleasure of introducing student Dr. Reid Wasserman. Student Dr. Reid Wasserman graduated summa cum laude from Hofstra University with a bachelor's in biology. He has also authored 2 guides that are entitled A Pre-Medical Student's Guide to the Medical School Admissions Process and A Brief for First-Year Medical Students at KCU, and distributed them to students to help them achieve their goals of medical students acceptance and first-year success, respectively. He also volunteers for Hope Recovery as a support group facilitator, which specializes in supporting adult survivors of abuse and sexual trauma on their journey of healing. Student Dr. Wasserman has recently submitted a case report study to the CHEST journal entitled Paget-Schroetter Syndrome, an underrecognized cause of upper extremity thrombosis, and plans to present this case at the annual CHEST journal meeting in October. Today, student Dr. Wasserman is going to be talking to us about a rare case of a gastric ulcer. So with that, I'll let you take it away. I ask, though, that everyone stay muted for the meeting, and we'll take any questions anyone has at the end.
So once again, my name is Reid Wasserman. I'm 4th year med student at Kansas City University, and I'll be talking about a case that I came across during my sub-internship here at Augusta University in the GI consult service. So the case report is entitled More Than NSAIDs or H. pylori, a rare case of a gastric ulcer. So first we're gonna talk about the patient presentation and a little bit about their history. So we'll begin now. So this was a 75-year-old female with a past medical history of diffuse large B-cell lymphoma, status post chimeric antigen receptor T-cell therapy, or CAR-T for short, and also GERD in their past medical history. So the patient presented, she woke up around 4 a.m. in the morning, feeling nauseous and vomiting bright red blood 2 times. The emesis also contained small blood clots, and the patient said she felt dizzy and passed out when she was on the toilet. Luckily, the patient's husband witnessed the fall and said that the patient did not hit her head on the floor. So upon the patient being revived and waking up, she had another syncopal event before the ambulance was able to arrive to her house. And when she got to the ED, her history was taken, and she denied any antiplatelet medications or NSAID use. She denied taking warfarin or any other anticoagulation medication. And she said that she received chemotherapy without radiation, and it was day 20 of her CAR-T therapy. She did receive an EGD in the past, which just showed a hiatal hernia. And she endorsed no history of smoking, alcohol use, or recreational drugs. And she said she had no family history of gastrointestinal disease or colon cancer. Additionally, the patient said she did have a bowel movement and had no apparent blood. She denied any kind of chest pain, shortness of breath, fevers, or chills, or diarrhea or constipation. And important to note, the patient did have a splenectomy in 2020 due to the lymphoma, the mass seen on her spleen, which was further identified as diffuse large B-cell lymphoma. So next we'll talk about her oncology history, which plays an important role in her history and presentation. So the patient said that she was having abdominal pain in 2019, and she had an ultrasound for her initial workup, which showed fatty liver disease and a splenic mass. So in April 2019, with a follow-up CT, the splenic mass was measured to be about 2 by 1.3 by 1.4 centimeters at the time. And then in August of 2020, she had an MRI that revealed her mass significantly grew to 9 by 8.5 by 8.9 centimeters. So the patient had a splenectomy in September 2020, and she also underwent staging with a PET CT, which showed residual lymph nodes present at the operative site in the left upper quadrant. So the patient initiated treatments with chemotherapy called R-CHOP, which stands for rituximab, cyclophosphamide, doxorubicin, vincristine, and prednisone, and she completed about 4 cycles of this therapy. And then a follow-up CD abdomen in January of 2021 showed nodules in the splenic bed that increased in size. So she had a follow-up PET scan obtained in February of 2021, which showed progression of the nodules in the splenic bed, as well as new areas of involvement, including the pancreas and fundus of the stomach. Her oncology staging was stage 2 diffuse large B-cell lymphoma of the GCB subtype of the spleen. And GCB subtype stands for germinal center B-cell. And I'm going to touch more about that later on in the presentation and why it's important. But for now, let's talk about the patient's medications and physical exam and labs. So you can see here the patient was taking lansoprazole, which is a proton pump inhibitor, or PPI, every day, dexamethasone, acyclovir, sulfamethoxazole trimethoprim, also known as Bactrim, and levetiracetam, which is Keppra. And important to note that she was on acyclovir and Bactrim for prophylaxis since she was in an immunocompromised state from her chemotherapy. So in physical exam, the patient was tachycardic with a heart rate of 107, and she was also hypotensive with a BP of 92/52. Most of her physical exam was benign, and her pertinent positives were her abdominal exam, which you can see here. She had left upper quadrant surgical scar when looking at her abdomen, and positive bowel sounds in all 4 quadrants, and mild epigastric tenderness to palpation. So looking at her labs, for the most part, her labs seem pretty normal, except for her hemoglobin. She has an anemia here with her hemoglobin of 6.5 with a baseline of 9 to 10. And she also has pretty low platelet count at 43. So she has a thrombocytopenia here as well. So for her assessment, we have hematemesis. As she came in, she presented with vomiting bright red blood and blood clots, as well as a syncopal event. Also a history of diffuse large B-cell lymphoma, status post this chemotherapy, and splenectomy. Thrombocytopenia, as her platelets were 43. Acute anemia. History of gastroesophageal reflux disease. History of hiatal hernia. So what are the differential diagnoses for upper GI bleeds? So most commonly, patients will have upper GI bleeds due to an ulcer, so peptic ulcer disease, esophageal varices if the patient has a history of cirrhosis or portal hypertension, a Mallory-Weiss tear, which is a tear in the mucosa of the esophagus, which can occur due to retching and commonly seen in bulimic patients. A Dieulafoy lesion, which can appear anywhere in the GI tract, and it's due to a submucosal artery that will just cause active oozing or spurting of blood. Anything that causes esophagitis or gastritis, and especially in immunocompromised, there always has to be the consideration of CMV and HSV. Of course, malignancy can cause upper GI bleeding. And then the last 3 here I highlighted are more rare causes of upper GI bleeds, but are still important to consider. And they are hemosuchus pancreaticus, hemobilia, and aortoenteric fistula. And for this last one, often there will be a history of a AAA repair. So now that we've talked about the patient's assessment and upper GI bleed differential diagnoses, we'll talk about our plan. So first, the patient has to be resuscitated with fluids and blood. And this is the first step, and you'll see later on the presentation when I talk about the ACG guidelines, this is the first step that the patient has to undergo before intervention. So the patient was given 1 liter of lactated ringer and 2 units of packed red blood cells. She was put on a PPI drip, and her hemoglobin and hematocrit was monitored, and also looking for any other signs of bleeding. The patient was kept NPO, so nothing by mouth, to prevent aspiration events and also for better visualization during endoscopy. And then important, also part of the ACG guidelines is to perform upper endoscopy within 24 hours of presentation. So about her upper endoscopy, the findings, which I have pictures that I'll show in a few minutes, there was a large amount of blood clots in the stomach that we were able to suction out. And then notably, there was a 5 by 5 centimeter actively bleeding ulcer found in the gastric fundus. And so temporary hemostasis was achieved with Hemospray, which is this powder, and I'll talk about that more in the presentation, which is also another modality used in hemostasis of upper GI bleeding. And then the patient was urgently consulted for interventional radiology for further embolization for hemostasis. So I have this picture here of the stomach, and I just wanted to go very briefly through the anatomy. So here you can see the fundus of the stomach, the body, the greater curvature, the pylorus, the antrum, and then leading into the duodenum. And so this patient's ulcer was found in the fundus right up against this wall. And so you'll see in the next picture that the endoscope will come through the esophagus here and will be retroflexed, meaning that it will be, the scope will be looking at the fundus here, so you can visualize the ulcer. So this is a CT scan with contrast. And just to have some orientation here, you can see this is the patient's right side and then the patient's left side. So you can see the liver here, and then the outline of the stomach wall. And then this big mass right here is the patient's splenic lymphoma. So it's quite impressive on this scan. And I put an arrow here to elucidate the fistulization between the splenic mass and the fundic wall of the stomach here. And so this was the area where the lymphoma was basically protruding into the stomach and causing this ulcer, ultimately leading to the patient's presentation. So this next picture is the PET scan. And so PET scans is an image test that reveals metabolic function of tissues, and it can show normal or abnormal metabolism of the radioactive tracer. And so when there's abnormal metabolism, it will light up, as you can see on the screen here. So basically all of this that's lighting up is the lymphoma in this patient in the abdominal cavity. And you can see right here where the outline of the stomach is, this PET scan is picking up where the lymphoma is protruding into the fundus of the stomach. So here you can see the picture on endoscopy. For orientation, here is the endoscope. And like I talked about in the previous picture of the diagram, the endoscope is being retroflexed. And so you're now seeing the fundus of the stomach. And you can clearly see this large ulcer in the wall of the fundus here. And it appears not to be bleeding in this picture, but we first were able to suction a lot of the blood clots out. And upon washing and flushing the ulcer, it did start to bleed as you'll see in this next picture here. So you can clearly see the fresh, bright red blood oozing from this ulcer. And so at this point, we needed to achieve hemostasis. And the way we did that was with Hemospray. And so the Hemospray, the way it works is that there is a CO2 powered device which contains this Hemospray powder, and it can be the attachment can be placed through the endoscope, and when turned on, it sprays this powder into the stomach. And you can see here this white powder covering the majority of the stomach area. And so what this powder does is that it activates platelets and coagulation factors to try and temporarily stop the bleeding. However, the patient was still actively oozing, and so it was decided that the patient needed to go to interventional radiology to have embolization. So you can see here the urgent referral to IR, and the patient subsequently underwent embolization of the left gastric artery. So to talk a little bit about the blood supply of the stomach here, you can see that the celiac trunk branches off the aorta, and the trunk has three main branches: the common hepatic artery, the splenic artery, and the left gastric artery. And so usually in patients, the short gastric arteries coming off of the splenic artery here, you can see supply the fundus of the stomach. However, in our patients, since they had a splenectomy, these short gastric arteries are essentially gone. And so you might wonder, well, how is the fundus of the stomach getting blood supply now? And so what happens in patients, and particularly in this patient, is that the left gastric artery can eventually provide collateral blood supply to the fundus of the stomach. And this was the case, as with interventional radiology, they were able to embolize the left gastric artery, and that was able to stop the bleeding and achieve better hemostasis. So the plan for this patient was for the patient after embolization to remain on a PPI drip, monitor their H&H every 6 hours and other signs of bleeding, and also to transfuse if the hemoglobin falls below 7 or if their platelets are below 50, and also, of course, to avoid NSAIDs, as this is one of the most common modalities that can cause an ulcer in patients. So to talk a little bit about diffuse large B-cell lymphoma itself, this is the most common type of non-Hodgkin's lymphoma. It is a cancer of B cells, and primary splenic DLBCL is a rare type of non-Hodgkin's lymphoma. So the symptoms of this lymphoma are fever, weight loss, night sweats, and if it gets large enough, it can cause left upper quadrant abdominal pain. And these symptoms are also known as B symptoms. This type of lymphoma can also cause cytopenias. And the way to diagnose this is through splenic biopsy or splenectomy. This treatment options include splenectomy only, splenectomy and chemotherapy with R-CHOP, as this patient underwent, or radiation with chemotherapy. And more about this lymphoma. So there are certain categories within this diffuse large B-cell lymphoma. And so the main category, not otherwise specified, actually represents 80 to 85% of all DLBCL. And 70% of not otherwise specified lymphoma occur in the lymph nodes. And so it is not very common to see this in the spleen, although there are case reports, and it does happen. So more about the subtype that I mentioned. This patient had the GCB subtype, which stands for germinal center B cell. And what this is based on the genetics, which is the translocation of the 14 and 18 chromosome. And what happens is that the BCL2 gene is close to the heavy chain enhancer and causes overexpression of the BCL2 protein. And this protein is responsible for preventing activation of caspases, which ultimately leads to apoptosis or cell death. And so, as you might imagine, since this BCL2 protein is not being inhibited, there is no cell death. So the cells will keep replicating and proliferating. So the last part is I want to mention about gastrosponic fistula, which is a very rare manifestation of diffuse large B-cell lymphoma. And there are about 26 case reports that I found, at least in the literature. And what it is that a fistulous tract forming between the stomach and the spleen. And so you can imagine this is a very rare manifestation. And it can occur, it can and does occur in two ways. The first way is through spontaneous tumor necrosis. And then the second way is secondary to chemotherapy-induced necrosis. And it was found that of the 26 case reports, only 9 were discovered after chemotherapy induction, which suggests that this complication presents less frequently than primary gastrosponic fistula not undergoing treatment. Also to note, the mechanism of action basically of the chemotherapy-induced necrosis is that the chemotherapy causes breaching of the splenic capsule, which will eventually cause this fistula. The last part of the presentation I wanted to review was the 2021 ACG guidelines, or American College of Gastroenterology, on upper GI bleeds and ulcers and what their recommendations are. And I think this is pretty important to go over because it's something that I encountered almost every day during my rotation. And the recommendations are very clear and provide guidance on how to manage these patients. And I'm not going to go through all of them, but I want to mention several here. So the first one I want to mention is the recommendation of red blood cell transfusion with a threshold for transfusion at a hemoglobin of 7 for patients with upper GI bleeds. And as our patient did present with a hemoglobin of less than 6.5, they did undergo transfusion. So we did follow this guideline closely. One of the things that's important here in this next guideline recommendation is the suggestion to infuse erythromycin before endoscopy in patients with upper GI bleeds. And erythromycin is actually a macrolide antibiotic. However, it has certain side effects such as increased GI motility and is actually used in the treatment of diabetic gastroparesis. Other side effects include QT prolongation, so it would be important to check the patient's EKG to make sure they have no underlying prolonged QT interval. Also, this erythromycin can cause CYP450 inhibition and intrahepatic cholestasis. So, like I mentioned before, the patient did undergo an upper endoscopy within 24 hours of presentation, like the guidelines suggest here. The next recommendation is that endoscopic therapy should be used in patients who have active spurting, oozing, or a non-bleeding visible vessel, which you can clearly see from that picture. The patient did have active oozing, so it was decided endoscopic therapy would be provided. Also, just to note in this recommendation, with the endoscopic therapy, the recommendation that epinephrine injection not be used alone for patients, but rather in combination, as the evidence showed that dual therapy with epinephrine injection was superior to epinephrine injection monotherapy alone. So other modalities can be the hemoclips or heat probe or APC, in addition to the epinephrine injection. The other endoscopic hemostatic therapy recommendation is hemostatic powder spray for patients with actively bleeding ulcers, which this patient did undergo Hemospray, as you saw in the previous picture. And then lastly here, the recommendation for high-dose PPI therapy given continuously for 3 days after successful endoscopic hemostatic therapy of a bleeding ulcer. It's important for the proton pump inhibitor for decreasing the stomach acid and to promote healing. And like we mentioned in the plan, for the patient to avoid NSAIDs, which would obviously hinder the patient's healing process. And lastly here, the recommendation for bleeding ulcers who have failed endoscopic therapy next be treated with transcatheter arterial embolization, which in this case our patient did undergo because we were only able to temporarily achieve hemostasis with the Hemospray. And so here are my references. And I wanted to just give a shout out and thank you to Dr. Cifuentes and Dr. Peng, who were my mentors and facilitators during my GI rotation. And I have to say I learned a lot from them. And also Dr. Stodinger, I wanted to thank for helping me with the presentation and giving me tips on my presentation overall. And so from here, I'll take any questions that anyone has.
Thank you for that presentation, student Dr. Wasserman. I have a question actually, and it's more of just, I'm a little bit curious, but how often do you see Hemospray used in hospital settings? Is that really specific to certain types of injuries, or can it kind of be used on a broader scale more frequently?
So like the guidelines mentioned, it's now part of the 2021 ACG guidelines. So I think this is, I'm not quite sure, but I think it is a newer modality to use this Hemospray now that it's mentioned in the 2021 guidelines, but I'm not particularly sure if it's used actively in the past. But the evidence so far suggests that it does provide hemostasis quite well. And since I've been here on my rotation, I have seen the Hemospray used multiple times for bleeding, for upper GI bleeds.
Awesome. Thanks. Yeah, I've never heard of something like that, so it's kind of new to me too, but thank you. All right. Well, if there aren't any other questions, I'm going to go ahead and end the recording. And thank you again, student Dr. Wasserman. That was a great presentation. Thanks for presenting for the Journal Club.
All right, thanks for having me.